tracks 10 policy areas. So we track budget, but we also track 10 of our policy categories. And these are very intersectional. Every year, and I did this when I first started in December, we put this list together, right, based on surveys that we sent around to our membership. I did the 2015 survey this last year, and we're going to send one around here in a couple months. And we asked about salience. What are the top issues that are most important to you as member organizations? And what are your preference? Is everyone kind of on the same page in terms of your preference on this issue? Is it kind of all over the place? And we formulate these 10 categories based on those things. So if it's an area that's really high salience with a lot of buy-in and a lot of preference that's polarized, then we make it a very specific category. If it's something that, okay, we kind of care about, our members are interested in this, I want to track it, we'll maybe lump that in with a couple of related categories. If it's something that we don't really get a lot of strong feedback about during our survey, we'll kind of lump that into our healthcare general or our miscellaneous category. This year, we expanded local waivers and block grants we expanded that out of the Mo Health Net and Affordable Care Act conversation. That'll probably be, again, a category again next year. Joel Ferber with Legal Services of Eastern Missouri and Jeff Oliver are going to give a wonderful presentation about those later today. So here's the other 5. So what I'll do here in this first presentation, I'll talk a little bit about general trends in the context of bills in the Missouri legislature that were almost passed, bills that were passed, and then I'll talk just a little bit about a few areas of concern in the budget, and then I'll move on to an Affordable Care Act update, but that's kind of the second piece of this. But for now, we'll focus on bills that almost passed, bills that, including the PDMP, bills that passed, and then a little bit of conversation about the budget. So, first bill that almost passed, and this was language that was on a few, different vehicles. House Bill 227, Representative Hubert's bill. That's a psychology interjurisdictional compact. Now, I don't know how many of you are familiar with that. I wasn't until very recently myself. It's a telecommunications, it's an interstate compact. So what it is it was proposed by the American Association of Psychology Licensing Boards as model legislation in 2015. And they approved it, got through their boards. Here in Missouri, it has been endorsed by the Psychology Licensing Board. In other states, I believe 5 other states, that has been the case. And in 3 other states, California, Nevada, and Arizona, that has been ratified. It will go into effect once 7 states have ratified it. So right now, it's waiting for other. Of course, it was only proposed in 2015, but it almost got across the finish line here in Missouri this year. It basically says, if you're a psychologist, you can practice psychology, you can treat patients through Skype, video conferencing, who you've met in other states, and if you have if you've established that pre-existing relationship with that patient over telecommunications, you can then cross state lines and treat that patient in person up to 30 days a year. So that's going to be a trend that will probably emerge next year if you're in that field. It may be important to you. As always, abortion and alternatives to abortion bills, big trend this year as always. They came really into 4 categories. Disposition of fetal remains, 2-parent minor consent for abortions, required reportings after abortion in facilities, and whistleblower protections for employees at facilities that provide abortions. Those whistleblowing protections are not new. I remember reading about them like 5 years ago, but they did heat up quite a bit this year in Missouri, so that is going to be a trend moving forward as well. HCD 10, that's our insurance omnibus bill. Again, these are bills that did not pass but got close. That insurance omnibus had a lot of stuff that I don't really, like festival insurance and stuff totally unrelated to health, but it includes some interesting pieces for us. The short-term medical policies in Missouri, it extends the length of the short-term medical policies that can be offered from 6-month maximum to a 12-month maximum. Now, those short-term medical policies do not, and they have to say this, they would have to say this clearly in the bill if it were to pass. They do not exempt you from the individual mandate if you're only covered under the short-term medical policies. Okay, so that's just kind of the clarification there. The suicide exclusion language that basically right now in the state of Missouri, it is illegal to sell to a market insurance plan, a life insurance plan, to somebody with a rider that says that if they die by suicide within a year of signing that, there we go, then the insurance won't pay. That suicide insurance exclusion was included on like 15 vehicles this year. I do not believe it passed on any of them. I haven't gotten through the whole thing yet, so tell me if I'm wrong, but I do not believe it passed. That's been something that's been a little bit divisive among the health advocates that I've spoken with, but it is something that's probably going to have quite a bit of momentum moving into the next session. Interest cap, so when there's a disputed claim between an insurance claimant and an insurance company, and that's adjudicated with the favor of the claimant, then the interest rate is capped, so the amount owed, multiplied by the time that wasn't paid. That's kind of seen as the tort reform type element, although it's not quite there, but it caps it by law in Missouri statute. And then the long-term care insurance rules and regulations, that was a piece that many of us did want to see passed. That had requirement that rates and quality of those long-term care policies be reasonable, and it capped it at a number. It capped it 20% increase, premium increase per year. Now, the PDMP, everyone in this room knows, we're the only state in the United States that does not have a statewide PDMP. I think that many people know the politics behind it. I'll be brief about, I won't go into, we'll have a whole session, a whole panel a little bit later, but I do want to talk through some of the provisions and some of the procedural posture on that. So the mainstream PDMP bill, rather than the alternative PDMP bill. So the mainstream PDMP bill, that's Representative Rader, Senator Schatz was the handler in the House. That's kind of the preferred bill. It's bipartisan, consensus was reached around it. That was the main vehicle. It went through the House pretty uneventfully. It got through the House floor with a single amendment that made it so that there was a required phase-in of a real-time electronic system for prescribers and dispensers to look at in a couple of years. That was the only amendment. When it got over to the Senate side, there was all kinds of changes. So and I think this is important too. One of the changes was made, the prescriber mandate was made in committee. That was in the Senate side. The other three major ones here, as you see, were made on the Senate floor side. So procedurally, the House was in a position on the Tuesday before session ended where they had, for 2 weeks at that point, both chambers had decided that they were going to conference on it, reconcile the differences between the two versions. The House, in kind of a surprise move, not very many people were there. It was me and like a few other people in the advocacy community that were around. It was like 9 or 10 at night, and the motion was made, I think it was Representative Barnes, I'm not sure, but the motion was made and passed to dissolve that conference committee, which in effect, this isn't technically true, but really politically, in effect made it so that the only choice that the House had on the PDMP was to pass the Senate version or no PDMP. That night, they never had that vote. That night I spoke with probably 50 legislators. I probably spoke with like 30 Democrats and 5 or 10 Republicans. The number one objection seemed to be the local preemption. And I think that was the piece that was added. Well, I don't know when it was added, but that was plain-faced, bold-facedly said, if this thing passes, it's absolutely going to preempt the St. Louis County-run and the other local municipality-run PDMPs. I just want to walk through a couple of the other differences in the provision. So right at the top there, the prescriber mandate. There are 13 states that have PDMPs that apply to both prescribers and dispensers, okay? This PDMP, this mainstream bill, in its original form, only applied to dispensers. Senator Schaaf, and I'm not sure whether it was in committee or if someone at the behest of Senator Schaaf, probably, maybe it was him, I'm not sure, added this prescriber mandate, okay? And it just made it so that the PDMP applies to dispensers and prescribers, which, if we're looking at it objectively, and I've done some research on other statewide PDMPs in the country, that's one of the metrics that makes a PDMP stronger or more aggressive. And I think that's true. I think it's objectively true. I think it would make it more aggressive to have it applied to dispensers and prescribers. Many people in Missouri thought and maybe these people are right, that Senator Schaaf put it in as a poison pill, that it was going to be too strong. I'm not really here to say whether that's true or not, but it is one piece of the Senate that was in the Senate version that was not in the House version. The other three were the other way. So the other three, the substance is covered. It's stronger in the House version. Senator Schaaf's, his amendment made it so that it covered all Schedule 2s, but then Schedule 3s and 4s it only covered opioids and benzodiazepines. The data retention limit, and I think this is important, it was a 180-day retention limit, so the database can only hold information for 180 days at a time. There are other states, I think there's 19 other states, I think that's right, 19 other states have data retention limits. Texas and 3 other states are the most, it's 5 years. Some of the other retention limits, I think, are like 2 years or 18 months. So 180 days would have been the shortest had it passed. The caveat here, and it hasn't really been talked about, is my reading of the bill, and people are free to, tell me I'm wrong about this, but my reading of the bill says the data retention limit did not apply to investigations that were already open. So if you look at subsection 6 of the bill, it gave all these reasons that law enforcement or the licensing boards, other agencies and organizations could access the EMP. If the investigation was already open, they have pulled that off anyway. So the reason why I'm saying this is when we get in next year, it's important to distinguish between a data retention limit and a enforcement information availability limit. Because if someone's got a drug problem now, they're probably going to be at risk for a drug problem 6 months from now. So it's very important to know that that information is there, regardless of whether I can access it or not. Local preemption, we talked about that as well. So moving on to the past bills, tort reform passed. The top priority for the majority party was union stuff. Tort reform was right there, collateral source rule, which we'll have a session on this afternoon. That passed. House Bill 452 that was language that was on a bunch of different bills that passed. Basically one section of that makes it did a few other things, but one section of that makes it a little bit harder to impute the actions or the negligence, recklessness of an employee or a physician assistant to that physician or to that hospital. Senate Bill 501, that was the bill that passed, like it just snuck up kind of out of nowhere. The House voted it down with like 19 amendments and with 2 weeks to go, and the Senate just adopted it. So it's got, in your folders, I have the chart, Senate Bill 501. Please do take a look at that. It's something that a lot of people may have missed. Something that you care about is probably in that bill if you're here at this meeting. The biggest things it did, EpiPens, so this is something we've been tinkering at for a while. Doctors and I guess the DHSS can prescribe EpiPens to sports camps and restaurants and stadiums and stuff for use in emergencies. The Narcan opioid antagonist, the Good Samaritan law. The Good Samaritan law in here is a good Samaritan law. It's not the strongest, but it's a good one. That's basically, if my buddy is overdosing, I can call for help, I can call for an ambulance without concern that I'll be arrested. Sadly, that makes it more, it's a reality that makes it more likely that person will call for help. There's a couple of exceptions in there. If you're violating parole, if you're violating a court order, and I think that's it. It's a pretty good law, it's a pretty good Samaritan law, and that's one that they have been looking at for a few years. If you go down that chart as well, there's a bunch of stuff in there about audiologist practice. I think there's some advanced practice nursing in there, and there's little bits and pieces about psychologist licensure and stuff as well. Senate Bill 139, that's one, really did not have a lot of attention. We did need to reauthorize that MHAA plan for it to continue. That has, I think it's 260 Missourians are on that plan. It was reauthorized as a part of that Senate Bill 139. I will also, in the last week, we were really stressed out because we thought it wasn't going to be reauthorized, which would have been terrible. In retrospect, our relief was a little bit misplaced, I think, at least speaking for myself, because, and we talked about this, how they added the dual eligibility requirement. You have to be eligible for both Medicaid and Medicare to continue on with the MORX policy, MORX pharmacy program. That will cut about 60,000 people off. The reauthorization will maintain about 200 people on that program. So there is going to be a gap there. I think ironically it's going to push a lot of the Medicare eligible people into being Medicaid eligible people. But again, that's just more in a general trend of general trend of Missouri politics. So also in that Senate Bill 139, there's a bunch of other stuff in there too. If you're interested in the pharmacy field, it's the adjustment of the polypharmacy program for at-risk health net beneficiaries. And there's a little bit in there that I kind of like about pegging the price that Health Net Division pays for its pharmacy, from its pharmaceuticals, to that pharmaceutical manufacturer's lowest price that they offer, which is a pretty popular provision. I kind of like that myself. In the Missouri budget, many of you heard about the circuit breaker tax cut, the point count. The point count will essentially remain the same. It will remain what it was. That's what the budget document said. The point count will remain what it is if this new senior protection fund is funded. The Missouri House wanted to fund it by eliminating the renter's portion of the circuit breaker tax credit, which basically only affects, as you all probably know, it only affects basically seniors on fixed income. The Senate said, no, we want to protect seniors. We're going to fund that by they call it a revenue fund sweep, or a fund sweep revenue. That's basically where they just take a look around the government departments in Missouri and say, who's got money left over, and they sweep it in. That's a one-year solution, so if they want to cut that amount of money next year, that fund sweep is probably not going to be available. It may, but it's not really a long-term sustainable solution to fund that. Just a couple of other things of note: Health Net Women's Services, that was cut to zero from $5.2 million. They did incidentally increase the funding for alternative to abortion agencies by $2 million. I guess the argument there would be that it goes to some of those services. It's not a great argument based on some of the budget people I talked to. Health Net Dental 2 years ago, that was funded at like $4 million. Last year it was funded at something like, I think it was like $15 million. This year they went back to like $3 million, it's like $3.9 million, so that was a huge backtrack in the budget there. Again, everyone's been talking about it, everyone's been hearing about it, it's all on the revenue side. We've had corporate tax cuts and proliferation of tax credits available for everything, and inability of the majority parties to close some of those, despite efforts on both sides to do so. So despite a generally improving economy, the revenue side continues to dwindle in the Missouri budget. So